Professor Gary Wittert, endocrinologist from the University of Adelaide, is going to talk to us today about adrenal disorders. Thank you so much for joining us today, Gary. We see a lot of people with polycystic ovarian syndrome, and it's got a lot of symptoms that are similar to the adrenal disorders. Could you just explain the difference between the two and maybe the things that would alert a fertility doctor to the fact that someone needed investigation and treatment of an disorder?
Sometimes it's not possible to tell clinically. An increase in androgens and a consequence of the increase in androgen. The symptoms of oligoamenorrhea or amenorrhea and those features that suggest virilism. There may be hirsutism, acne, male pattern balding, clitoromegaly, and an increase in sexual desire. That's the androgen component of this. I don't really think unexplained weight gain differentiates between ovarian and adrenal, unless the weight is very specifically centripetally distributed, if it's associated with loss of muscle mass and proximal muscle weakness, and if it's accompanied by striae, that could be indicating that there's excessive cortisol production along with the androgen. There may be fatigue, there may be muscle weakness, abdominal pain, or changes in skin pigmentation, which reflects an elevated ACTH secretion. So, of course, we're talking about those features that we might be concerned about because of Cushing's syndrome as a cause for increased androgens or an adrenal carcinoma, except that usually occurs in older women. So some of the key differentiating factors I should be concerned or not about depends firstly on the age of onset of the symptoms. Someone who's 56 or 58 or 60 who's never had any problems and presents with elevated serum androgen concentrations and symptoms and signs of that is going to raise concern. The second is the rapidity of onset, how quickly the symptoms and signs present. And then the third parameter is the hormones. If the testosterone is normal, BG tends to help. If the SHBG is 15, I'm dealing with a problem that's probably more related to a lower SHBG than an elevated testosterone. If the testosterone is over 3 point, then I'm going to start getting concerned. And if the testosterone is over 5, then I'm very concerned there's a pathological problem present. Okay. DHAS comes from the adrenal. It's an end product of dihydroepiandrosterone metabolism. It's differentiating between an adrenal and a non-adrenal cause. And I want to know what the 17-hydroxyprogesterone is in the mornings for non-classical congenital adrenal hyperplasia in the mornings, because that's when ACTH levels are maximal. ACTH is a hormone that's produced in the anterior pituitary gland from cells called corticotrophs. It's the hormone that initiates the cascade of serotogenesis in the adrenal gland. You may want to do an ACTH stimulation test and have a look at what the 17-hydroxyprogesterone does.
You also mentioned the ACTH stimulation test. Can you tell me why you do that and what that shows?
ACTH is a hormone that's produced in the anterior pituitary gland from cells called corticotrophs. It's the hormone that initiates the cascade of serotogenesis in the adrenal gland. So it's important for glucocorticoid production and, in fact, irreplaceable for glucocorticoid production because there's no other stimulus to that. The ACTH stimulation test is stimulating the pathway. So what you're doing is you are flushing out the underlying abnormality. So normally with ACTH, you get an increment in 17-hydroxyprogesterone of a certain magnitude. But if there's underlying non-classical congenital adrenal hyperplasia, you get a much more magnified increase, and that's because of the relative enzyme block. And so it's a useful test. It's important for mineralocorticoid production to a certain extent, but there are backup mechanisms for that. And then it's important for the production of sex steroids. And in a woman, of course, a portion of testosterone is produced in the adrenal gland. Most still comes from the ovary, but at least in premenopausal woman, some does come from the adrenal gland. TH is also interesting in that it's synthesized from a larger molecule called pro-opiomelanocortin. And one of the cleavage products of ACTH is alpha MSH, which acts at the MSH receptor. to induce pigmentation. ACTH in high enough concentrations can also act to some extent at the MCH receptor, inducing a degree of pigmentation. Usually this is something in Addison's disease. It's not common for ACTH levels to be high enough in other conditions, but sometimes in Cushing's you can get a little bit of pigmentation. There's a condition called Nelson syndrome where someone with an ACTH producing tumor gets the adrenals removed, and then you get this hyperplastic response from the tumor and very high levels of ACTH, and people can get extremely dark as a consequence.
So do you ever measure cortisol? And there's lots of different ways you can measure it. What would you recommend if you were going to measure cortisol, or do you think it's not worth it?
I would do a morning fasting serum cortisol and an ACTH, because what I'm looking for is an ACTH that's discordant with the cortisol. If I want to know if there's too much cortisol, then I do 24-hour urine, I find. Or you can do a midnight cortisol, helpful, if there's loss of the diurnal rhythm. And that's fairly easy to do by giving patients a cotton wool bud and collect the salivary cortisol. There are stimulation and suppression tests, but by the time you've suspected that it's Cushing's or some significant adrenal disorder, then off to the endocrinologist you go. And it's up to them to work it out. And they'll be delighted to do that. Also, you could consider in adrenal disorders whether the mineral pathway is abnormal. Blood pressure should be measured posturally, standing and sitting, and at the same time measure the pulse to see how that changes. That will tell you too much or too little mineralocorticoid. And then you measure a morning seated aldosterone and plasmarenin activity. And you could also do a spot urine for sodium, potassium, and creatinine ratios, along with the bloods, to see what you're dealing with in the mineralocorticoid pathway.
So Gary, if we thought we had a diagnosis, are there any kind of emergency things that we would need to think of in terms of giving hydrocortisone, or are there any conditions that we've got to be particularly aware of that you ring the endocrinologist to get advice on if you're worried about them? In terms of the use of steroids or steroid supplementation that hasn't been taken or things like that?
I think if a question crosses anyone's mind, have a low threshold, just call the endocrinologist and ask for advice. And better to ask for advice before you do something. If someone has omitted a dose of cortisone, they're going to know their diagnosis and why they're taking cortisone. And if they're vomiting and they can't take the cortisone, then give it parenterally. You won't do any harm by doing that. Omitting it, you will do harm under those circumstances. And that's more people with classical congenital adrenal hyperplasia. But I don't think there's any other situation here where urgent intervention is required.
What about if we have someone with one of those conditions and we're trying to induce ovulation? Do we need to do anything extra or special to actually get the egg to come out? Or can we just use our FSHs and our clomids and letrozoles? Is there anything that would be a specific issue?
Are you talking about congenital adrenal hyperplasia?
Congenital hyperplasia. And I must say, I've generally used FSH alone, but they've been on supplementation. And I've not had to do too much differently from what I've PCOS.
No, if they've been well treated, there shouldn't be a problem, and the usual approach should apply. If they've been over-treated with hydrocortisone, or if for some reason someone put them on dexamethasone, then you may find that there's a problem with side effects of glucocorticoid that are iatrogenically induced rather than coming from the adrenal gland themselves.
Just a side issue is occasionally you get someone who, when you do blood tests, they always have a high progesterone, and you can often suppress it with a corticosteroid. What's the physiology behind that, Gary?
The short answer is I don't know, but I would always be suspicious about the assays, because if the assay is not a tandem mass spec, then there are a lot of progesterone-like compounds that the assay could be picking up. And particularly in an individual where the degradative pathways may be a little bit different. People also take things that they don't tell us about, particularly over-the-counter compounds. Someone might be slapping yam cream all over themselves, or they're on a progesterone-only contraceptive, or they forgot to tell you about the Mirena and those kind of things. So I think rather than taking it as a disorder of the HPG axis, I would want to resolve those other issues. And I think the standard immunoassay might be problematic in that respect.
So can I ask you just one more question about Cushings? And we're probably going to wrap up soon. Primary Cushings, secondary Cushings, how do you explain that to your registrars and to fertility doctors and people who don't see it very often?
What Cushing's basically is, there's too much cortisol. That cortisol can come externally because you've taken it in some way, shape or form, injected, swallowed. It can be taken by an inhaler or it can be applied topically. And I've seen Cushing's induced by the administration of corticoid by any of those routes, because people's ability to metabolize glucocorticoid differ substantially. And some people are very sensitive to dexamethasone. In the smallest dose, they can't break down. It accumulates very rapidly and they become Cushingoid. And in someone who's on glucocorticoid like that, when you measure their own cortisol first thing in the morning before their daily dose, their cortisol will be suppressed, their ACTH will be suppressed, and their DHEAS will be suppressed. If it's endogenous Cushing's, the adrenal gland is making too much cortisol. The commonest situation is that there's a small pituitary tumor with an excess production of ACTH. So that's called pituitary-dependent Cushing's or ACTH-dependent Cushing's. But ACTH can also be made elsewhere, and the commonest place is a lung cancer. That's called ectopic ACTH production. It's very often in an aggressive situation with rapidly progressive Cushing's, often to the extent that you get hypokalemia. And that's one of the situations where you're more likely to get muscle weakness. And it's not only the lungs. You can sometimes get carcinoids from the gut that make ACTH. Then you can get Cushing's because of abnormalities in the adrenal gland. And in that situation, the ACTH will be suppressed. It's relatively straightforward. And also, if the problem is ACTH, you remember right at the beginning, I said that ACTH stimulates all of those pathways. So you'll find that there's an increased mineralocorticoid activity and there's increase in adrenal androgens. But if you've got a glucocorticoid producing tumor in the adrenal gland, that generally only produces cortisol. So you can have some peripheral clinical pointers to the origin of Cushing's. Another situation is when people are drinking too much alcohol. And you can get alcohol-induced pseudo-Cushing's, where they have all the features of Cushing's.
What about insulin? What happens when your cortisol's high or low to your insulin levels? Does that change your metabolism?
So cortisol is a stress hormone. It will increase the supply of energy. It will mobilize fuels. It's glycolytic, so it will break down glycogen in the liver to form glucose, and it induces insulin resistance in muscle and the liver. And if you have too much, then it'll start breaking down muscle to release amino acids that can be mobilized and used as glucose. If you're going to work up a patient from an endocrine perspective, the biochemistry must follow the history and examination. And please don't image anything until you've got a clinical syndrome and biochemistry that points you to what the likely possibilities are, because there are lots of accidentalomas or misinterpreted radiological findings. And then you go off on a goose chase looking for things that may not be there. And that causes all manner of confusion.
Right. So what are the most common imaging tests that you use?
If you're going to look at the ovaries, then a starting point would be an ultrasound. CT or MRI will look at adrenal tumors or adrenal hyperplasia. Fine section CT with contrast can be extremely good. And then sometimes you can't tell where the androgen's coming from, and then selective venous sampling of the ovary and adrenal can be undertaken.
Look, that's been a fantastic discussion, Gary. I think all of us would have learned a lot from that. And I really appreciate just the way you've presented that so we can understand when and what to do. So thank you very much. It's one of the first podcasts we've done in this series. I'm sure a lot of people will be watching it across the Asia Pacific for ASPIRE, who's sponsoring this.
My pleasure, and thank you so much for asking me.